Dr. Mukherjee, thank you for joining us.
Yeah, you're very welcome, Alex. Thanks for having me.
Yeah. So I'd just like to start out, if you could just talk a little bit about your role at the hospital and what you're doing to kind of prepare for the response, because I think that even though you've got patients now, your peak is still predicted to be several weeks away.
Sure, absolutely. So my role is, so I'm the pulmonary critical care physician here at a community hospital, and the medical director of the ICU, and also with pulmonary lung cancer screening. So part of my preparation as the medical director is trying to really work with the hospital administration and trying to make sure that everything is in order. Mostly, as you can imagine, this has been something that has taken a lot of planning, from how we manage staff and reallocate resources within the hospital to how we make sure that we're getting all the equipment necessary and keeping tabs on things. It's not just medications for COVID-19. It's not just ventilators. It's also, and it's not just PPE. It's also things like central lines and equipment necessary to IV tubing and filters on the ventilator and all those things that we need to work through on a daily basis. So we're meeting several hours a day with hospital administration, coordination within the healthcare system. Most hospitals are part of a system as well, and so coordination amongst the different hospitals within the system, making sure that things are in line with formulating a process that is uniform across the system is also a challenge, because each hospital has different needs, different demographics, and so that's something that has been a challenge for sure.
Got it. And I'm wondering if you can talk a little bit about what is it about this disease that makes it so burdensome to hospitals and requires so much preparation and planning.
Absolutely. So I think, when you look at the data on, and actually there was something just published recently in JAMA with about 1,200 patients that were seen in Italy, and of those patients requiring intensive care admission, what the survival was. And I think that's really the big issue is, yes, the majority of patients who will have COVID-19 will do okay. The problem really is that when you are tiered into that severe category, the mortality, unfortunately, is very high. And so that requires a high level of support from an oxygenation standpoint, and typically progresses to the need for mechanical ventilation, high levels of positive pressure within those little sacs in your lung, the alveoli, to help with recruitment, and high flow oxygen sometimes just does not do the trick. And so progressive multi-system organ failure and shock oftentimes come with this, and so that's been a challenge, and the number of patients is certainly overwhelming hospitals to deal with all at once.
We hear a lot about ventilators and kind of the need for those. Could you explain a little bit about what is it about this disease that requires the use of ventilators, and then how are you handling kind of the shortages of them?
Sure. So, one of the challenges with this disease is that it has been, it's a short period of time that we are dealing with these relatively in terms of the medical community and analyzing the data and doing clinical trials. So things are changing on a daily basis. And really what we know based on the data so far is that there's a rapid deterioration, and these patients require mechanical ventilation earlier rather than later. And the reason is based on some of the data that we have. Non-invasive positive pressure ventilation, or CPAPs or BiPAPs, or sometimes what we use in the hospital for respiratory support, those patients tend to have a worse outcome. Now that is changing as we look at some more data there's a movement to maybe not jump to intubation as quickly. And that's something that we are looking at and really trying to get better data on. However, based on some of the numbers that we see coming out of Italy and China, most of those patients will require that level of support. So the other reason that we don't, that mechanical ventilation is needed is because if you do non-invasive positive pressure ventilation with, say, a BiPAP machine, that mask that is on that patient has to have an expiratory port of some kind, and that is considered an aerosolizing process. And so that patient is then aerosolizing the virus on that non-invasive positive pressure, and therefore that presents as a challenge for the hospital, the employees, the respiratory therapists, and all the nursing staff, and so that's been a big challenge for us to try to keep everyone in the hospital safe, make sure that we are protecting and conserving the use of PPE, but also making sure that we treat patients. So that's something why that I think leads to earlier mechanical ventilation as well.
Got it. So are you looking to ways where maybe you could avoid the use of intubation by protecting either the workers or disinfecting the room or doing something to kind of keep that aerosolized virus away from infecting more people?
Absolutely, yeah. There are multiple things that we have done within the healthcare system. One of those is with the use of filters and making sure that we use appropriate bacterial, viral filters in addition to the HEPA filters that are on, or in addition to the current HME filters that are on the circuits. Some of those filters can be reprocessed. There's a national shortage of all of these things, and as you can imagine, tubing with the circuits, the filters, all of these things, there's a shortage of. And so I think systems are looking into reprocessing some of these things and different sterilization techniques. But in addition, we are getting creative in terms of ways that we might be able to place patients on mechanical ventilation. The intubation process, putting a tube down someone's throat and hooking them up to a ventilator, is a high-risk procedure for hospitals and for patients, and so we are trying to create barriers to do so with coverings and video laryngoscopic procedures that allow a little bit more of a distance between the provider and the patient, and some of those things. So we are getting, as time goes on, we're trying different techniques to help with avoiding mechanical ventilation just to protect the aerosolization. We're also using higher flow oxygen with non-rebreather masks and high flow oxygen nasal cannulas in addition, as long as the patient's able to tolerate it from a oxygenation standpoint.
Got it. I'm going to take a few questions from the audience now. Our social media team has been diligently reading through what you've been doing. And for those of you just joining us, we're talking with Dr. Sumit Mukherjeee, explaining how hospitals are preparing for and dealing with the COVID-19 pandemic. So one of the questions we're getting from the audience is, in terms of the ventilators, do you think that the need for them is going to have a lasting impact beyond this pandemic? Should we be stockpiling more in the event of future respiratory illnesses? Should we be worried about, I know there have been reports of kind of longer term damage to the lungs. What do you think about in terms of not just preparing for the next few weeks, but the next few years?
Sure. Yeah, I think what will be interesting to see is, and important to figure out, is how this is going to affect us in the coming years with seasonal variations. And so I think there's been a lot of discussion amongst the virologists as far as whether or not this is we're able to control this, or if we're going to be dealing with this in subsequent seasons and it's going to be something that returns. So certainly if that's the case, we are going to need that level of, and hopefully we're able to find a vaccine and a treatment that will make this less prevalent. But yes, I anticipate general respiratory illnesses and the need for mechanical ventilation to continue. Absolutely.
And one of the things that I've seen, people talking about in the news, and this is another question from the audience, is that are there other medical devices that can kind of, in a pinch, be converted to ventilators? And is this kind of something that, if so, that you had to do before, or is this kind of new territory?
Sure. Yeah. No. So one of the things we're looking at within, several hospital systems, not just our hospital system, but we are looking at converting BiPAPs into ventilators. Essentially, a lot of them have the ability to do so. There's a special type of BiPAP called a V60 that is able to transition to a pressure control ventilation mode, and we are able to run certain types of mechanical ventilation on that BiPAP machine. We sometimes are not able to provide the level of support necessarily fully on those machines, but for the most part, they can do most of the things that we are looking for when we're doing respiratory support. The other things that are out there that we've seen are, particularly with transferring patients from one part of the hospital to another, bag mask ventilation with PEEP valves on them that are able to provide positive pressure and help ventilate and oxygenate patients. Although some of that is controversial because of the risk for aerosolization, but we are placing filters in them and pieces in them to help during the transfer. But so there are several devices, even some home ventilators that you may hear about, which are essentially fancy BiPAP machines. Mm-hmm. We were able to help with mechanical ventilation. And then lastly, ventilators that are used in the operating rooms are slightly different than the ventilators that are used in the hospital wards, generally in the ICU. Some of those ventilators, within our facility, if we anticipate a surge to meet those requirements, I think we may be using some of those ventilators as well.
And that, for those in the audience who might not know, could you just briefly let us know what is a BiPAP machine?
Sure. BiPAP machine is when you think about a mask on someone and oftentimes used for patients who have sleep apnea, CPAPs and BiPAPs. The difference between a CPAP and a BiPAP is that a BiPAP administers 2 levels. It's a bi-level, non-invasive ventilator that essentially helps you breathe out carbon dioxide. It aids with expiration. And so those BiPAP machines, because it's helping with an inspiratory pressure and an expiratory pressure, can also help you ventilate, can help you breathe. And so that's something that we have been utilizing.
Got it. So a lot of times during other, kind of tragic events, big emergencies, things like that, hospitals often call for volunteers. But one question that we're getting from the audience out there is does the presence of the virus, does that make it harder to get volunteers and mobilize the community to help out the hospital, or you kind of figured out some ways that people can help without, exposing others to risk?
Sure. I have been amazed through this process, the outpouring from the community and from folks that even within our hospital, employees and families of employees, people that are just wanting to reach out and help, whether it's bringing in food, creating masks and supplies. There's a lot of people that can do 3D printing and things like that for face shields, and we're having a huge outpouring of folks that are willing to help and donate to hand sanitizers. There's companies around that are donating a lot of hand sanitizer. Things like that have been very, very helpful. But yes, in terms of keeping people safe and keeping people out of the hospital, it's difficult. We want to make sure and protect not only our hospital employees and our staff, patients, but also the visitors. And so we've had a very strict policy with visitation within the hospital. And so if we're bringing a lot of volunteers in from the outside and family members aren't able to come in and see their loved ones when they're extremely ill, that creates a problem. And so that's something, yeah, we have certainly had some challenges with that. We're just trying to keep everybody safe.
And speaking of keeping people in the hospital safe, what are some things that you're doing, maybe yourself and also the people on your staff, to kind of reduce the risk, not only within the hospital, but also, when you're out in the world and you're with your loved ones?
Sure. The hospital system in general that I work for, and I think a lot of hospital systems around the country have been great with providing some of that support and making sure that we change things like particularly stations where folks can change out of their clothes, lockers, changing out scrubs and things like that for safety purposes. Some of the emergency and support staff are staying. The hospital and healthcare system have arranged areas where they can stay if they need to be close to the hospital or away from their families. And so those things have been beneficial, certainly. But constantly having people who are in the hospital, who are in charge of who are in our incident command and who are on the floors and on the ground, basically trying to educate people on how to manage PPE, how to conserve PPE, how to sterilize, where you go, what you do, because this is all very new for so many of the folks that are in the hospital. Everybody from the cafeteria staff and the facilities management that are walking around the hospital and exposed. It's a constant education process. So absolutely, there's a lot of work that's being done there.
Got it. Well, we're running close to the end of our time, but I think we can take one more question from the audience, and that's just: do you think that this pandemic is it a wake-up call for countries about the need to allocate more resources to hospitals, to emergency response, to epidemic preparedness?
Yes, absolutely. I think this is a wake-up call, and I know there's been a lot of conversation and politics behind this all in terms of being prepared. But certainly, this will happen again at some point, and this is something that I think we need to be prepared for. And I realize that there's an emergency stockpile, but I think it is incredible how quickly the system can break down if the demand is there for all of these things. Of course, ventilators are in the news mostly, but you're talking about simple plastic tubing and filters and things that you don't really even think about on a daily basis otherwise. And so absolutely, I think we should certainly be prepared better next time around for this. And I hate to live in fear. Certainly I think we all would like to get back to our normal lives, and but this is going to have a lasting impact on the community, on our economy, and on our hospital systems. And we definitely need to change. One of the things that our hospital has done is change an entire floor to a negative pressure ventilation. So we're able to, previously we only had a few rooms here and there, but there are ways to just change an entire unit and that's expensive for hospitals, and it's very challenging sometimes. But those types of things, we've never really thought about having to have an entire floor filled with patients who need negative pressure. But this is something that has come in useful, and we're dealing with these challenges, but some foresight. I think now we will learn from this experience and hopefully be better off.